Good morning, and thank you organizers and dear colleagues for inviting me to Calcutta for this conference. And today I will be speaking on robotic thoracic surgery, and greetings from Medanta, from where I come. And we are a center where we have two robos, both Da Vinci, and now the third one is just on its way. We do mostly urological surgeries, but yes, thoracic surgery as well as gynae and transoral robotic surgeries have also been done, although the volumes are not as much as urological procedures. So in my presentation, I will take you across basically the design of the robo, what the OR needs to be like, what are the advantages of robotic surgery, the procedures that can be done with the robo, the anesthetic considerations, and the emergency and locking trim. So we all know, if we look into the basic design of the robo, it consists of three parts, whatever robo we look, the most common being the Da Vinci. It has a console where the operating surgeon sits. There is a patient sidecar which has 4 interactive arms. These may be all combined into one or as isolated interactive arms. And we have a vision cart which holds your optical devices. It may hold the insufflator. It may also hold the recording device and the robotic camera. So all of them are present in one cart. So when we look at the OR, this is how it looks like. We have the surgeon who's sitting at the console, and we have the patient end where we have the assisting surgeon who are going to be putting in the instruments, and there are multiple screens into which the assistant surgeon as well as the anesthetist can look into and see what is going on. So it actually needs a large footprint or a large space, otherwise the whole OR becomes too crowded. So if we do not have good foot space into the OR, because it's a bulky equipment, we have to ensure that the OR size is good enough. What are the advantages of robotic thoracic surgery? The advantages that it offers is it's minimally invasive, like we have VATS. Hence it results in less pain, decrease in the hospital stay, and reduced morbidity. Also, it offers a 3-dimensional view for the surgeon and results in excellent maneuverability. It provides great ergonomic comfort to the surgeon, and the instrumentation specifically offers 7 degrees of freedom and hence allowing for safe and complex dissection. The biggest advantage of this is that when we compare it to open or to VAT surgery is that the surgeon can reach into areas which are otherwise not easily accessible. For example, if we are looking into thymectomies, we can do an clearance right up till the brachiocephalic vein. If we are talking about cancers or malignancies, then there is a complete lymph node dissection, which is much better than VATS, which can be offered by robotic surgery as compared to only VATS surgeries. And in this recent publication, we can clearly see, which came out last year in 2022, if we look at the overall survival of patients who were undergoing surgery by robotics, the overall survival was much better with RATs as compared to VATs and open. The recurrence was also much lower with RATs as compared to VATs and open surgeries. And specifically, if we looked into cancer survival, also it was much better in compared with robotic surgery as compared to VATs or open surgeries. And what are the procedures that we can carry out with robotic surgeries? We can carry out both diagnostic as well as therapeutic procedures. The diagnostic procedures include all your pleural biopsies, thoracocentesis, even staging for lung and pleural cancers and malignancies, diagnosing of parenchymal diseases, fibrotic nodules and pneumonitis, diagnosis of mediastinal tumors, thymomas or sarcomas, as well as for diagnosis of pericardial disease and tumors. On the therapeutic front, all surgeries which are possible with open or VATs possibly can be carried out, which include decortication, segmentectomy, lobectomies, pneumonectomies, also mediastinal thymectomies and chylothorax surgeries, esophageal surgeries like vagotomies, myotomies and esophagectomies, as well as the sympathectomies. Let's look into the anesthetic considerations. The basic preoperative anesthesia evaluation is same as in any other open or VATS procedure. Meticulous attention needs to be paid to the pulmonary, cardiac and the airway examination. Specifically in myasthenic patients, a good history and evaluation of the current medications with history of bulbar involvement, hospital admission, immunotherapy and myasthenic crisis needs to be taken into account. In your pre-op workup, other than the routine investigations, cardiac workup depends on the patient's requirement. A PFT is a must in all our patients, and if we have if the PFT is not good, then additional investigations like the ABG and the CPET should be done. A CT is a must in all your thoracic patients because it gives us an idea of understanding the pathology, the airway caliber, abnormality and vascular involvement. It helps us to guide the size of the tube that we may be required to isolate the lung, and it also gives us an idea into the lines required or where we should put the lines, especially if we are talking about patients who have large mediastinal masses. In the pulmonary function test, it is high risk if the FVC is less than 50% or our FEV1 is less than 2 liters, or the FEV1 FVC ratio is less than 50%, or the RV TLC ratio is more than 50%, or the DLCO is less than 50% of the predicted. And on ABG, if the PaCO2 is more than 45 or if our PaO2 is less than 60, then all of these warrant that we need to do additional tests. The additional investigations may include in the form of a CPET. If we don't have a CPET, then a 6 meter walk test, or we can do the stair climbing tests, are all useful parameters which can help us to guide the post-op outcome in these patients, because these are extremely useful for prognostication and also to quantify the perioperative morbidity and mortality. An anaerobic threshold of more than 11 ml per minute or a VO2 max of more than 80% of the predicted are very good indicators which will help us to predict good post-operative outcome. The standard, if you look at the anesthesia consideration, it is always general anesthesia with endotracheal intubation. A double lumen tube is what we use. We have to place a orogastric tube in advance. DVT pumps have to be used. Fluid warmers and forced airway warming blankets are a must to prevent hypothermia. And we try to follow a restrictive fluid strategy, but a euvolemia is what is being followed these days. The special considerations include lung isolation, one lung anesthesia, positioning of these patients, the additional monitoring that we need to do, how difficult it is to access these patients, and that of capnothorax. In looking at the lung isolation devices, it is basically the left-sided double lumen tube is preferred because there is a lesser chance of it being displaced as compared to a right-sided tube or a bronchial blocker. Because the access to the patient is difficult, especially in robotic surgery, we always have to do a flexible bronchoscopy to confirm the tube placement, which we will do once we have placed the tube, then again once we have positioned the patient, and again the third time before the surgery starts, because once the robo is docked and the surgery is on, it is very difficult for us to reach the patient and try to do any manipulation of the tube, and hence we always try, if not indicated, use a left-sided double lumen tube. Only if there is a very specific indication, go in for a right-sided tube, and bronchial blockers, I would say, is a real big no-no if we are considering a robotic surgery. Protective lung strategy has to be in place, where we are going to use a low tidal volume at the rate of 2 to 4 ml per kg with a higher respiratory rate. Routine use of PEEP to the non-operative lung with low ventilatory pressures. Use as much as a low FiO2 as possible. We don't aim for 100% saturation, but anything more than 92% is acceptable. And use permissive hypercapnia as long as we can keep our pH above 7.25. And limit the duration of our one lung ventilation to less than 100 minutes as far as possible. Positioning of the patient basically is the two important positions is the lateral position which we use for our lobectomies, and the supine position, the extreme supine position which we use for the thymectomies. When we are doing a lobectomy, then obviously the patient is flexed at the mid-thoracic level to open up the thoracic spaces. A gel roll is placed anteriorly and posteriorly to hold the patient. A hip strap needs to be applied to stabilize the patient, and an axillary roll has to be placed to elevate the axillary space and prevent any neurovascular compression, and all pressure points need to be padded. Arms are extended outwards parallel to each other with the elbow flexed. The upper limb is placed on an airplane fixture. The bottom leg is flexed and the top leg is kept straight with a pillow to prevent injury to the common peroneal and the saphenous nerve. The head has to be placed in a neutral position with anatomical alignment to avoid brachial plexus injury, and the eyes have to be padded to prevent corneal abrasions. So this is what the patient looks like when he is placed, for a patient in the lateral position for the lobectomy. When we talk about thymectomy, it is an incomplete side-up position with at a 30-degree angle. The arm on the elevated side is placed as far back as the patient's side, and adequate padding and pressure points have to be provided. The brachial plexus safety is a big concern, and hence we have to ensure that the arm is not extended too far back during the robotic thymectomy. So this is what a patient looks like when he is placed for any mediastinal mass or a robotic thymectomy position. As far as monitoring is concerned, an invasive arterial line is mandatory for all the robotic anesthesia thoracic surgeries. Central venous access is based on the patient's comorbidities and the extent of the surgical dissection required. For prolonged procedures, a catheter is required, and otherwise the standard ASA monitoring is mandated. Specifically, we are talking to thymectomies and patients of myasthenia, then intraoperative neuromuscular monitoring should be done. The electrodes can be placed over the course of the ulnar nerve. If it is difficult to access, then they also can be placed on the forehead, and the orbiculis oculi muscle can be monitored for that. Monitoring, if we have, then the advanced hemodynamic monitoring tools are a must. Although in the open chest, they are not very useful to guide the volume resuscitation, but a trend can be used to check and help us and give us a guide as to how much fluid is required. Restrictive fluid therapy may be good for the lung, but it is not really good for the kidney, and a liberal fluid therapy is not adequate because of pulmonary complications. Goal-directed fluid therapy may not be very reliable in thoracic surgery. Hence, euvolemia with crystalloids is generally targeted with a rate of 5 to 7 ml per kg per hour. The access of the patient is extremely difficult. We really cannot approach the patient once the robo is docked and is in place, and hence we always have to plan all our lines, extensions, long circuits as well as backup IV accesses much before in advance. Whenever we are using airway isolate, whatever the airway device that we choose, confirmation of its correct placement once the patient is in the final position is of paramount importance, and the venous and arterial accesses need to be positioned to enable access but also to prevent snag and trip hazards. Once we have everything has been done, a trial run should be done before the final docking of the robo is done, so that there is no drag or being pulled in any of the lines or the circuit. The other thing that we need to of importance in robotic thoracic surgery is the capnothorax and the CO2 insufflation that we use. The important thing is that if it is a multi-speciality robo and the insufflator is being used for all your urological, gynae as well as thoracic procedures, always ensure that it has been set to 0, and it is, once we are using it for the thoracic, then they are actually set at the pressures at only 1 and 3 and not at the standard abdominal pressures, because otherwise there is a high incidence of developing a pneumothorax or some kind of gas embolism. So the other important thing which we need to keep in mind is, in contrast to VATS, in which the chest cavity is open to the atmospheric pressure, during RATS the carbon dioxide is insufflated through sealed ports, and hence it creates a positive intrathoracic pressure of 5 to 10 centimeters of water. This allows for better operating conditions by encouraging lung deflation and flattening the diaphragm. So malposition of any internal retractor or too much of CO2 or capnothorax can cause compression of the cardiac or mesovascular structures, resulting in hemodynamic instability with EKG changes, and emergency defibrillation may not be possible with capnothorax. Also, it can cause bradycardia and hypotension because of the compression of the mediastinal vessels. Carbon dioxide insufflation can result in hypercapnia, which may be challenging to manage, especially with one lung ventilation. And pneumothorax and venous gas embolism have also been reported. The other important things are that the robo cannot move in response to the patient's movement, and hence the OR table has to be switched off once we have docked the robo, and proper depth of anesthesia always has to be monitored, and preferably if we can do with the neuromuscular monitoring. Post-op analgesia in these patients is generally multimodal, and we can use NSAIDs as well as short-acting opioids. Epidural and paravertebral are needed only in patients, or maybe if it has been converted or the incidence of going into an open surgery is high. Otherwise, newer blocks like the serratus anterior plane block or the erector spinous block or a paravertebral is also good enough. And long-acting opioids are generally avoided, especially in the myasthenic patients. An emergency drill is something of paramount importance, especially if you are working in the robotic theatre, because there are a large number of situations where we may have to go into a plan B or into an open thoracotomy. It is important for the team to have established and a rehearsed drill for rapid undocking and removal of the robo from the surgical field. The thoracotomy tray, sternotomy tray and a saw, cross-batch blood should all be readily available, and role of clarity of the OT personnel as to who is going to do what once a crisis happens should be very clearly defined. a chart like this can always be placed in the OR theatre, where the red is an emergency which highlights of acute importance. For example, if there is an airway compromise or there is a cardiac arrest or a code blue kind of a situation. For example, if we need to re-intubate the patient, or there is loss of the surgical airway, or there is an extreme blood loss and CPR needs to be here, it is the anesthetist who is going to play the important role in driving this drill. The yellow may be an uncontrolled hemorrhage, where the surgeon is going to play a pivotal role, and where it may just have to undock the robo and go into an open thoracotomy or a laparotomy. And the third may be minor issues, like there may be a robotic malfunction or a breakdown, where the whole team can decide as to what the plan can be. And hence this kind of a drill is extremely important, and it should be there in place. Contraindications of robotic surgery include previous surgery or radiotherapy, extensive pleural disease, central or endobronchial lesions, large tumors which are more than 6 centimeters, and patient who has restricted cardiac function. This is what a radical thymectomy specimen which looks like. There is complete resection. We can take out the tumor. Also, we can take out small lymph nodes, as well as go and expose right up till the brachiocephalic vein, and hence a complete dissection is what it is available to us when we are doing a robotic surgery. So if we want to start a robotic thoracic surgery program, the selection of patients is extremely important to ensure that they are anatomically suitable for the resection and have minimal comorbidities. Cost considerations are high, and hence they should be kept in mind. But the cost comes down once we have a large number of patients or procedures which can be carried out with this process. So it is something which is there in the future, and we should embrace it. Thank you. And I'd like to invite you all for the National Annual Conference, which we are organizing by Haryana, and is being organized in Gurgaon this year.
Thank you, madam, for the nice deliberation. Any question from the audience, please?
Thank you.
Then the next speaker is Dr. RSACPCON, and the topic is advanced hemodynamic monitoring. Please.